Welcome to Multidisciplinary Approach to the Management of CRS with Refractory Nasal Polyps, ENT, allergist, and patient partnerships to enhance care and quality of life. This is presented by Global Education Group and ImmunologyLive.com. My name is Dr. John Basso, and I'm clinical professor and allergist immunologist at the Perelman School of Medicine, University of Pennsylvania. Today's session is interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. Noam Cohen, professor of otorhinolaryngology, head and neck surgery at the Perelman School of Medicine, University of Pennsylvania. Thank you, Noam, for joining me today. Let's get started.
All right, well, thank you, John. I'm going to move on to our next slide, which is our disclosures. And then the learning objectives for the next hour are the following. The first is to describe the burden of disease faced by patients with recurrent nasal polyposis or those who are not eligible for systemic corticosteroids. The second objective is to summarize the data documenting the efficacy and safety of these new targeting T2 inflammation biologic agents, including impacts on quality of life and other bothersome symptoms for people that have refractory nasal polyps or recurrent nasal polyps after functional endoscopic sinus surgery, as well as for those, again, who are ineligible for systemic corticosteroids. And third is to recognize the place of the biologic agents in targeting type 2 inflammation in the management of patients with chronic rhinosinusitis and nasal polyposis. And lastly is to describe strategies to engage patients with nasal polyps in shared decision-making to enhance access to patient-centered care and improve patient satisfaction and quality of life. So chronic rhinosinusitis is a syndrome that is defined by two or more of the following symptoms that have a duration of at least 3 months. So nasal blockage, obstruction, congestion, nasal discharge or purulent drainage, facial pressure or pain or periorbital headache, and reduction or loss of sense of smell. Classically, chronic sinusitis was divided into two broad categories based on their phenotype. So there's chronic rhinosinusitis with without nasal polyposis and with nasal polyposis. The disease without nasal polyposis was more of a chronic infection. And when you looked in the nose, you can see in the top left here, there's a slide of a maxillary sinus draining purulent discharge. On CT scans, we would see air fluid levels, and you can see thickening of bone or osteitis or osteomyelitis. And pathologically, chronic rhinosinusitis without nasal polyps was predominantly in the Western Hemisphere a neutrophilic-driven disease. In contrast, chronic rhinosinusitis with nasal polyps, when you look endoscopically, you see these big, fleshy-looking objects that almost look like skinless grapes. Radiographically, there's near complete opacification of the sinuses. And pathologically, nasal polyps are basically filled up not with neutrophils, but with eosinophils. We see that patients with asthma, that patients with nasal polyps, about 20 to 60% of them will also have concomitant asthma. And if you take all nasal polyp patients or all asthma patients, about 7% of them have concomitant nasal polyps. We also see nasal polyps in other diseases such as cystic fibrosis with a genetic disorder, but the polyps associated with cystic fibrosis, while they look like skinless grapes, pathologically, they're more neutrophilic. The characteristics or the symptoms are also different between chronic sinusitis with and without nasal polyps. Patients without polyps predominantly are complaining of symptoms that go along with the common cold. So facial pressure and pain. They have nasal obstruction or blockage, and they have purulent nasal discharge, either through the front of the nose or for postnasal drip. Patients that have chronic sinusitis with nasal polyps don't often complain of pain or pressure. Their predominant symptom and complaint is loss of sense of smell. And while they can't breathe at all through their nose, they don't seem to complain about it. As I said, it also goes along with concomitant asthma and with aspirin hypersensitivity. And this is what polyps look like. So on the far left is an extreme example of nasal polyposis, basically with complete nasal obstruction. You can see the polyps growing out of the patient's nostril. In this individual, it was so severe that he developed something called Wilkes syndrome, where the polyps expanded the bridge of his nose and caused telecanthus. So his eyes were actually more wider than they should have been. A little bit more discrete is the middle panel, where you can see endoscopically a discrete polyp coming out of the middle meatus and draping down over the inferior turbinate to the floor of the nose. And just to give you an appreciation of how many polyps we can pull out of a patient's nose that has chronic sinusitis with nasal polyps is a Petri dish. That's a 10-centimeter dish filled up with polyps from one side of the nose. So that's the polyp burden that we often run into with these patients with severe nasal polyposis. The prevalence is somewhere between 2 and 4% across the globe. In the United States, it's the numbers are around 4%. In Europe, it's a little bit lower, and in Asia, even lower. If you take all chronic rhinosinusitis patients globally, between a quarter and a third of them will have concomitant polyps. And we also know that patients that have chronic rhinosinusitis with nasal polyps, it's more common, slightly more common in males, but the disease in females is more severe based on quality of life metrics. The average age of onset is in the fifth decade, so mid-40s is when we start seeing nasal polyps presenting in the clinic. As I said, that there are comorbid conditions, and having nasal polyps will make your asthma worse. We see it along with allergic rhinitis. Certain subtle immunodeficiencies can manifest with chronic rhinosinusitis with nasal polyps. Anatomic deformities rarely can cause nasal polyps. They predominantly cause chronic rhinosinusitis without nasal polyps. The aspirin exacerbatory respiratory disease is on the spectrum with chronic rhinosinusitis with nasal polyps. And as I mentioned, cystic fibrosis does form polyps, but it's a neutrophilic polyp. The added value, or the added component of polyps on asthma make it much worse, and I'll discuss that in an upcoming slide. The diagnosis is based on nasal endoscopy. And while you can use, here I have a demonstration of a rigid nasal endoscope, you can also use a flexible nasal endoscope. And that allows you to get a little bit past the nasal vestibule and look in the middle meatus, where the majority of these polyps form. So they're coming off the ethmoid mucosa, and it allows for looking for either discharge or polypoid degeneration. Using an endoscope allows you to get deeper into the nose, not to just look at the middle meatus, but at the sphenoethmoidal recess where the sphenoid and the posterior ethmoids drain. Polyps are graded 0 to 4. No evidence of polyps is a grade 0. If you see polypoid degeneration up to the level of the middle turbinate, and that's what you can see on the endoscopic view in the bottom right, is a polyp forming out of the middle meatus. The middle turbinate is off to the right. If the polyp gets to the level of the middle turbinate, it's a class 1. If you see polyps below the middle turbinate, it's a class 2, or a score of 2. Medial to the middle turbinate, so between the middle turbinate and the septum, is a grade 3. And if it goes down past the inferior turbinate along the floor, it's a grade 4. And so you score this on both sides of the nose, and so you have a total range of 0 to 8, higher, reflecting a higher polyp burden. The influence of polyps on asthma make it substantially more severe. You have harder to control the asthma if they're polyps. There's more airway obstruction. There's more inflammation. And patients with polyps that also have concomitant asthma have higher frequency of polyp recurrence after treatment and more severe rhinologic symptoms when they have concomitant asthma. And this speaks to the concept of the unified airway, that airway epithelial inflammation begets more airway epithelial inflammation. And whether it's a trigger in the nose that is activating the inflammatory cascade in the lung, or vice versa, is not necessarily sure. It's also not sure whether it's direct communication of cytokines that are being aspirated in the mucus, or if it's these cytokines that are getting into the blood and activating the same receptors in the lower airway. But the idea that the nose can trigger the lung is now well accepted and is underneath this category of the unified airway. As I mentioned before, the main way to diagnose this is with nasal endoscopy, but you can also use anterior rhinoscopy. And so here's a demonstration of a nasal speculum. Note that you open it up and down, not side to side. And here you can see large polyps that are in the front of the nose or in the nasal vestibule. Here's a demonstration of a more fibrous polyp, and this is probably a little bit of an older polyp. It doesn't have that grape-like appearance, but it's the same thing, filled up with fibroblasts and fibrosis and eosinophils. And this is what you can see with anterior rhinoscopy. So the combination of anterior rhinoscopy and nasal endoscopy will allow you to clinically diagnose polyps. And then we have radiographic support as well. So the modality of choice is a non-contrast CT scan, which will allow you to, in detail, visualize the pneumatization or lack thereof with opacification of all sinuses. So you can see the frontal, you can see the entire ethmoid labyrinth, the sphenoid, and the maxillary, as well as the OMC. And so on the left side there, you can see well-pneumatized frontal sinuses, whereas on the right, you can see complete opacification, and either that's retained mucus or polyposis. It's not necessarily sure what the opacification is, but it's not pneumatized. In rare instances, we will then move on from a CT scan if there's other symptoms or signs, and I'll get into that in a couple slides, that would warrant getting an MRI scan, which would help further diagnose what that opacification might be. So we're getting to our first audience participation question, and I'm going to throw this out to you. At the current state, how comfortable are most people in the audience with diagnosing chronic rhinosinusitis with nasal polyps and what they can expect from treatment? So John, I'm going to pose to you a question. I was trained as a otolaryngologist, and a big part of my residency was learning how to scope people. You're coming at it from a very different angle, from allergy immunology, which I don't think is part of the residency. So how did you pick up diagnosing patients with chronic rhinosinusitis with or without nasal polyps?
I think my fellowship, we were really the National Referral Center for aspirin exacerbated respiratory disease. So we really saw a lot of sinus disease. And I fortunately had a mentor who was very much interested in having the fellows learn how to do a nasal endoscopy. And so I think that's really where it started. I also remember taking a course at the academy, but having a special interest in sinus disease from early on, I think forced me to be, to want to learn the procedure, and knowing how much you miss when you really don't, when you're not able to do an endoscopy on your exam.
All right, well, the results of our poll are back, and the most common answers were for A and B, that the staff or the care provider provide a very thorough explanation, or that the staff provides explanation along with resources for the patients so that they can understand what's going on with the disease. So interestingly, while the polling question with the healthcare provider would suggest that you guys feel that you're very, very good at explaining the disease to the patients, when we asked a similar question a month ago to a group of patients with chronic sinusitis, it was nearly the reciprocal response, where 0 responded that they fully understood what to expect from both the disease process and the treatment. 33% somewhat had an idea of what was going on, and 67% were pretty surprised and really had no comprehension of what was going on and nor what to expect. Okay, so moving on. So now that we've talked about the disease, I want to get into the principles of what we're trying to do taking care of these patients. And so the goal of management is really based on the patient's symptoms. And I should really focus on that. At the current state, there are no specific guidelines that address potential for biomarker-driven treatment decisions. And that's really the frontier of chronic rhinosinusitis, both without and with nasal polyps, is trying to understand all of the biomarkers that are driving this disease so that we can do biomarker-driven treatments. So the goals really are to reduce polyp size, make the patients feel better, improve their quality of life, and then ultimately to prevent recurrence. And I should state that polyps tend to be the gift that keeps on giving. If you don't manage them long-term, they will come back. So there are multiple consensus statements. This is probably the most recognized. This is the European Position Statement on Sinusitis that was published in 2020. And it gets into a big care algorithm. So initially, the frontline therapy for patients with chronic sinusitis with polyps is intranasal corticosteroids, Initially, if we don't have infection, we don't like to treat with antibiotics. And then the other component that goes along with the anti-inflammatories is good nasal lavage, so saline irrigations. And so those are fairly straightforward interventions. And typically the recommendation is for 6 to 12 weeks. If patients improve, great, they can stay on their nasal steroids and their irrigations. And if they don't, we escalate it up to refer to either a allergist immunologist or an otolaryngologist. At that point, we will go over and make sure that the appropriate medical therapy, that the nasal steroids are actually getting instilled into the nose properly. And I should stress that 90% of patients are actually putting steroids in their nose incorrectly. They're spraying it against the middle of the nose, the nasal septum. The polyps and all the inflammation happens on the lateral wall. And so the easiest thing to talk to your patients about is hand opposite the nostril. When you instill nasal steroids, you hold it in the hand opposite the nostril. So if you're spraying it in the left side, you want to hold it in the right side. And you want it pointing to the corner of the contralateral eye so that the spray actually gets onto the inferior turbinate and the lateral wall. So that's the first thing, just getting the medication where it belongs and really stressing the therapeutic potential of nasal irrigations. If that doesn't seem to improve their symptoms, then a CT scan is warranted to really determine the degree of burden. And at the same time, nasal endoscopy to look for whether there is infection that you can culture. And at that point, if we can get microbiology results and antibiotic resistance data, we can put them on appropriate antibiotics. If all that fails, then we can move on to either surgery. There are alternatives also for enhanced steroid delivery, either adding the steroids into the irrigations or with exhalational devices that I'll talk about a little bit later on, just to increase the penetration of the anti-inflammatories into the nasal cavity. And then lastly, when all that fails, we can start looking at these targeted biologics that are going to basically block components of that type 2 inflammatory cascade to see if the polyps can be shrunk and reduce the recurrence rates. Another subset that we didn't really talk about, which is somewhat of an oddball, but you will see it especially in humid environments like in the Southeast, is allergic fungal rhinosinusitis. This is a little bit of an atypical sinusitis. It's often unilateral. Radiographically, it shows up with increased densities in the opacification. You can see a lot of scary things on the radiology, like bone thinning. It can protrude up into the brain or into the eye, can present with proptosis. But again, this is just an extremely exuberant type 2 inflammatory response to a fungal colonization, not necessarily a fungal infection. And the treatment for that is surgical debridement with then steroids, both topical and systemic steroids, to reduce that inflammation, along with immunotherapy. So the other things that are alarming, where we talked about the MRI, is things that are a little bit more sinister than your garden variety polyps. And so if you see periorbital edema or erythema, if you got a periorbital cellulitis, any visual changes is something to be worried about, which would warrant getting an MRI. Severe headaches that don't seem to respond to even the anti-inflammatories, any swelling of the forehead, any neurologic symptoms, any of this would suggest that there's something else going on besides just your garden variety nasal polyps, and an MRI at that point would be warranted. And so again, excuse me, the overall focus of the therapy is to reduce the polyp size. And this is in patients who have not had surgery, and to try to treat any exasperations and to reduce any long-term treatment for steroid use. And so one of my colleagues once said that if systemic steroids didn't have a side effect, as rhinologists, we would be out of a job. And so it's okay to every once in a while treat nasal polyps with a steroid burst and taper, but it can't be the kind of thing that they're systemically on because of all of the systemic side effects. And so we're really looking for steroid preserving type of therapies, or localized steroid where you're not going to get all the systemic effects. So as I mentioned before, the cornerstone really is the nasal spray. The problem with nasal sprays is it really just treats the inferior turbinate. It doesn't really get that far deep into the nose where the polyps are starting into the middle meatus. The enhanced delivery system uses exhalational. It's a lot more effective. It's a retrograde flow where you actually blow into the device. It goes down one nostril. Because you're blowing out, the soft palate closes off the nasopharynx, and that spray actually comes retrograde through the contralateral nostril. When the medication is delivered from the nasopharynx to the nostril, the anatomy of the sinuses actually drives that spray laterally and superior, basically where the polyps are starting. So the enhanced delivery systems are exceptionally effective at delivering the steroid to areas that the classic nasal sprays do not. And then lastly, we can add the steroids into our high volume irrigations. And so you're basically flooding the entire sinonasal cavity with a steroid wash. And here's a demonstration of that contralateral flow, where it goes up the left nostril and it's flowing out in a retrograde manner through the right nostril. And in that retrograde manner, it's actually penetrating up into the ethmoid, potentially up into the frontal, and definitely into the maxillary sinus. And it improves not only the delivery of the steroid, but the mechanical lavage of all the inspissated secretions and infected secretions. Now, we briefly talked about antibiotics, and our line is that you don't give antibiotics unless you have a culture. And here's a demonstration of an endoscopically guided culture. We use these very small culturettes called Calgi swabs that are malleable, and we can really thread it through the nostril without contaminating it to the colonizing bacteria of the nasal vibrissae and get into the actual area that's infected. Send that off, and we will typically get microbiology and with sensitivities, and the usual management is 10 to 14 days of systemic antibiotics that are culture driven. There's limited data out there on topical antibiotics. However, we still will use those from time to time in patients that have multi-drug resistance, and we can get much higher concentrations of antibiotics topically in the sinonasal lavage. So when all that fails, that's when we start entertaining the idea of surgery. And when we operate, what we're trying to do is remove the polyp burden and remove all the small bony partitions that allow for all that inflammation to happen. And so what we're really doing is decreasing the surface area of the respiratory mucosa in the sinonasal cavity and allowing for our topical anti-inflammatories to get better penetrations into the sinonasal cavity. And so the patients that are candidates for surgical intervention basically have had to fail the conventional therapy of topical systemic anti-inflammatory steroids, antibiotics, irrigations. And when they are still having symptoms, then we will offer them surgery. And so the idea behind the surgery is to, as I said, reduce the surface area of the mucosa and remove all the bony partitions. And so you can see on the left side of this schematic what a non-operated cavity looks like. And on the right side is a post-functional endoscopic sinus surgery. And so what we're removing is all those little bony partitions. And the idea is to increase the ability of mucociliary clearance to drain all those inspissated secretions, even in the face of inflammation. And so by reducing the surface area and by taking out all these bony partitions, even if the mucosa is edematous, the mucus will still be able to drain. And more importantly, is we will be able to access all of that sinus mucosa with our topical irrigations. And so radiographically, this is what a non-operated paranasal sinus cavity looks like on a sagittal view and on a coronal view. And you can see all those bony little partitions. And after surgery, what we're trying to get is a skeletonized cavity, a wide open marsupialized cavity where the skull base is clearly seen, the medial orbital wall is clearly seen, and you can see right into the sphenoid. And so this is an ideal post-surgical cavity. Again, the medial orbital wall is skeletonized, the skull base is skeletonized. We've reduced a lot of the surface area where the inflammation takes over. And this patient overall is exceptionally happy after a surgery. Here's the same surgery, but you can see that there's still mucosal edema and inflammation. And so this patient intermittently is coming in with persistent signs, or is coming in with intermittent signs and symptoms that can be treated with a short course of some prednisone. And then this is a patient that we've operated on, skeletonized cavity, and has a complete opacification of all of the sinuses. And so what are the biologic causes for surgical failure? Well, either we didn't treat the underlying disease and there's still recurrent or persistent inflammation, and we see that with recurrent polyps, or that the inflammation has gotten deeper than the mucosa and has gotten into the bone. And you can see that in that second image where you see all that osteotic bone, and that's usually from mucosal stripping at the time of surgery, or that there's persistent infection like biofilms. And you can see that in the far right image where you have pus pooling in the sinonasal cavity. So at this point, I'm going to switch over to John, and he's going to take over the higher cognitive function where we start talking about the future with endotype-specific management.
Thank you, Noam. So ideally, you'd love to treat patients based on biomarkers, especially these refractory patients. Obviously, the patients that respond really well to simpler management are not going to require the more expensive and more long-term biotherapies. But ideally, if you can know what the unique inflammatory signature of each polyp is, you would know which would be the best therapy for that particular patient. And one example of an early identification of a subtype is that for several years, we have been treating patients with AERD, aspirin-exacerbated respiratory disease, with aspirin desensitization, followed by long-term aspirin therapy, because of the suppression of inflammation that occurs just in this particular subtype when they take aspirin after desensitization. If you look at endotypes, so Noam spoke a lot about phenotypes, and what we're going to shift more towards endotypes, which are mechanistic subtypes and molecular components of those. And patients who have either CRS with or without nasal polyps can have various endotypes. So the classic nasal polyp patient has, in the Western world, about 85% of them will have the type 2 inflammation that was alluded to, which is really mediated by the key cytokines of IL-4, 5, and 13, ILC2 cells. There's inflammation that is primarily eosinophilic. There's release of cysteinoleukotrienes. And these patients have a greater risk for asthma. They have a greater risk for recurrence, and they tend to have more severe disease. Now, the other types are the type 1 and type 3, which tend to be more neutrophilic types of inflammation, with IL-17 and 22 being associated with type 3 inflammation, and interferon gamma being associated with type 1 inflammation. If you look at the patterns of inflammatory endotypes in all forms of CRS, again, in the Western world, and more specifically, it can be country specific, but you can see here that patients with nasal polyps on the far right, that 87% of them have some form of type 2 inflammation. About 2/3 of them are pure type 2, and some of them have mixed type 2 with type 3, type 2 with type 1. But even in CRS without nasal polyps, there's a fair number of patients that have, at least 55% of them have some form of type 2 inflammation. So it's key that we understand that the type of inflammatory endotype the patient has, so that before we go ahead and give them specific therapy. So I was part of this interdisciplinary expert panel of allergists and rhinologists, and this was published in IFAR last year. But this is basically a group of guidelines, and Noam spoke about the diagnosis with the cardinal symptoms and the objective findings, and starting with intranasal corticosteroids, but a lot of patients not responding, some patients requiring short bursts of oral corticosteroids. But oftentimes patients will start out with intranasal corticosteroid sprays, maybe a burst of oral corticosteroids. And if they do really well with that after a month, then obviously we're going to continue that therapy, and that's going to be the end. But most patients are really not served by that therapy. And so with persistent symptoms and evidence of extensive disease, we're going to consider testing. We're going to work up patients who may have atopic with allergy testing, because in some situations, allergies can play a role, particularly in what we call central compartment disease, which is primarily ethmoid and nasal polyposis. We're going to consider an aspirin challenge in patients who we may suspect have AERD. We're going to do a lab workup. A basic lab workup should be CBC with differential and a total IgE level. And if we suspect that they're a very difficult patient, we may consider an ANCA because of the ruling out EGPA. Noam described the enhanced delivery system, and it contains fluticasone as its steroid, the one that's available now. And that would probably be the next step for a lot of patients who, before any more severe types of therapy. You're going to potentially consider maybe one more burst of corticosteroids before you escalate their therapy. But most patients will end up requiring escalation of therapy, which for most of them at this point, when they're refractory, we're going to consider sinus surgery. And for those patients, the majority, we're going to discuss with the patients, okay, what is the extent of surgery? What's the purpose of surgery? As Noam mentioned, it is to help deliver medical therapy. And that medical therapy is intranasal or intrasinus corticosteroids, topical corticosteroids, because that should be the first line, just like they are for persistent asthma, topical corticosteroids. So if that is effective, that is going to be the long-term therapy. However, if symptoms persist, despite those interventions, then perhaps this is a patient that should be treated in a comprehensive multi-specialty management approach. And so there's where you're going to consider, okay, if they have AERD, we may consider aspirin desensitization and reassess that at 6 months. If they have asthma or other comorbidities, we may consider them early on for a biologic, a type 2 biologic. We're going to speak about those in more detail in just a moment. And then, of course, we may consider another burst of steroids, or if we're not happy with the surgery, revise the surgery. And then there are these steroid sinus implants that can be used, particularly for localized disease. Now, in a minority of patients who have very severe asthma, despite standard therapy or the oral corticosteroid-dependent asthmatics, or if there's a patient who has a contraindication of surgery, they're a poor surgical candidate, or if they really, really have declined surgery through a shared decision-making process, we may consider early on going to a biologic. So let's talk about biologics in the management of CRS with nasal polyps, because they are a formidable therapy for refractory patients. And we now have them available, and we didn't have them available a number of years ago. And so this model shows the typical type 2 inflammation with the breakdown of the airway epithelium by pollutants, microbes, and oxidative stresses. And once that epithelium is broken down, you have the release of these epithelial cytokines, which basically are TSLP, IL-25, and IL-33. And then you get stimulation of ILC2 cells, mast cells, and B cells, and then you get the adaptive immune response. And everywhere along these pathways, there's a biologic that's been either approved or studied for blocking these mediators, and again, which ones for which patients are really still the issue. And we're going to discuss the major agents in the coming slides. So the emerging agents or the current therapy, so dupilumab, mepolizumab, and omalizumab is what we're going to spend most of our time on. These are currently FDA approved for CRS with nasal polyps refractory to standard therapy. Other therapies that are in study right now and in phase 3, benralizumab, tezepelumab. Benra is a anti-IL-5 receptor blocker, and then you have a number of anti-IL-33 agents, agents that block the prostaglandin D2 receptor, like fevipiprant, and the thromboxane antagonist ifetroban, which is being studied for AERD. So if you look at the European criteria, the European guidelines, which I think are really reasonable guidelines for the biological therapy of CRS with nasal polyps, the patients that should be considered are patients who have bilateral polyps. And in those who have had sinus surgery already, 3 criteria are required. And if patients have not had sinus surgery, there should be 4 of these 5 criteria satisfied. So what are the criteria? Evidence of type 2 inflammation. What is evidence of type 2 inflammation? You need to have tissue eosinophils greater than 10 per high-powered field, or blood eosinophils greater than 250, or a total IgE level greater than 100. Now, these patients that really are significantly in need of corticosteroids not only have type 2 inflammation, because without type 2 inflammation, they're not going to respond to type 2 biologics, but patients who get repetitive oral corticosteroid bursts should be considered for biologics. So patients who get more than 2 courses a year, or if they're on long-term low-dose corticosteroids, you're going to consider them. Or if their quality of life is significantly impaired, as identified by a SNOT-22 score of greater than 40. SNOT-22 is a questionnaire of 22 questions, sinonasal outcome test, and 40 is a moderately high score. Or patients who have a significant loss of smell, as noted on objective testing, or patients who have comorbid moderate or severe asthma that requires regular inhaled corticosteroids. So these are the primary criteria. And that European expert board also mentioned that not only should you have a criteria for starting biologics, but what about whether or not patients are responding to biologics? And so 6 months seems to be the expert guideline time that most therapies are going to work by that point. And you'd like to see some objective changes. Is there an improvement in sense of smell, nasal congestion scores, nasal polyp scores, SNOT-22? If the patient does not have any of those objective criteria, you're going to stop the therapy, or you're going to consider surgery, or you possibly may switch biologics. If the patient responds well and they're happy, then you're going to continue therapy. And of course, anywhere in between, if the patient seems to have objective improvement, but they're still not happy, you may consider salvage surgery under biologic protection, or you may consider another course of oral corticosteroids. Let's talk first about dupilumab, which is the anti-IL-4 receptor monoclonal antibody, which blocks the IL-4 receptor alpha, which basically prevents the signaling of IL-4 and IL-13, which are 2 of the 3 major cytokines involved with type 2 inflammation. We were involved in the dupilumab Liberty Sinus 52 study. There was also a Sinus 24. The 24 is a 24-week and 52 is a 52-week. In the 24 study and the 52-week study, patients had a run-in with 4 weeks of mometasone nasal spray, the standard mometasone furoate nasal aqueous spray. And then after that, they were divided into 24 study. Half of them went into dupilumab, 300 milligrams subcutaneously every 2 weeks, and the other half got placebo every 2 weeks. And then there was a 12-week off-treatment follow-up. And for the patients in the 52 study, there were 3 groups. One group got 300 milligrams every 2 weeks. Another group got 300 milligrams every 2 weeks for the first 24 weeks, and then switched over to 300 milligrams every 4 weeks. And then there was also a placebo group. These were adult patients who've had prior surgery or systemic corticosteroids. They had a high nasal polyp burden with a score of at least 5 out of 8 and greater than or equal to 2 per nostril. And they had significant nasal congestion or loss of sense of smell or rhinorrhea. And as you can see, the results are reasonably robust for the dupilumab group. There was a reduction in nasal polyp score of about 2 points, maybe 1 per nostril, but that could certainly be enough to make a patient be happy and maybe increase their nasal airflow and sense of smell. And the congestion score is also reduced by 1 on a scale of 3. So there was, and also their CT scores reduced, not shown on this slide. The other key thing is that for the placebo group, about 40% of those patients required systemic corticosteroids while on the study, whereas patients who were getting dupilumab, only about 12% of those ended up requiring either nasal surgery or systemic corticosteroids. And for the most part, the adverse reactions were not that severe in the initial studies, where there are injection site reactions, conjunctivitis, which is a common one, seen more commonly, though, in atopic dermatitis-treated patients. Arthralgias and gastritis were other symptoms that were seen, but at a lower percentage. And in the FAERS data, which is the FDA approval of the FDA data that occurs after post-marketing, there were a little bit more in terms of adverse events seen Dermatologically, about 14% of patients did get some form of a rash. And there were about 13% of patients who had generalized symptoms like arthralgias, injection site reactions at about 10%. But you notice that the polyp patients seem to have a little less in terms of adverse events than patients who were treated for asthma and patients who were treated for atopic derm. Now, omalizumab has been out since 2003. It's an anti-IgE monoclonal antibody, and it blocks free IgE, which is circulating. And then by blocking free IgE, it basically reduces the amount of IgE that binds to the IgE receptor on the mast cells and the basophils and other cells that have IgE receptors. And so there's a reduction in the high affinity receptors because there's no free IgE in the serum. And so the receptors internalize, and that therefore reduces the release of mediators, which reduces inflammation and then obviously improves symptoms. There were two identical trials that were done with omalizumab, phase 3 trials, the Polyp 1 and Polyp 2, and they basically were very similar. And what this was similarly to the dupilumab study, they were run in with intranasal corticosteroids. They were treated for 24 weeks with either omalizumab or placebo, and the same kinds of parameters, nasal polyp scores, et cetera, were looked at, SNOT-22 scores and smell scores. And what you can see here is that there was a significant reduction in the size of the polyps, not as indirectly, doesn't meet the level that was seen in the congregation of dupilumab patients, but you can see here there's about a little over 1 point reduction in nasal polyp score and about a 3/4 point reduction in the nasal congestion score, which is still very significant for patient treatment. And then what you can see in the open label study, in the patients who received a placebo on the left, they actually had a significant improvement in the open label part of the treatment. And the patients who had already responded continued to respond. But you also see, just like in dupilumab, patients who, once they're off therapy, they start rebounding. So there is no disease modification that occurs with these drugs. Once the patients are off the drugs, they slowly go back to their baseline status. And the quality of life also, there was significant reduction with omalizumab in the quality of life, and the mean clinically important difference of a SNOT-22 score is about 8.9 or 9 points, which was reached in the study and exceeded and it was about a 15-point reduction in the quality of life score, and primarily in the domains of nasal symptoms and impact on sleep. And the adverse events were also minimal, with injection site reactions being most significant. Some patients with the headaches and arthralgias were also seen. The other FDA approved, so we talked about the first two were FDA approved for polyps, and the third is mepolizumab, which is also FDA approved CRS with nasal polyps that refractory to standard therapy. Mepolizumab is an anti-IL-5 monoclonal antibody, which basically binds to IL-5 that's circulating and prevents it from binding to its receptor. And reslizumab is also, we're not going to speak about that, that's an IV form that's not FDA approved. It has the same mechanism of action. And benralizumab, which is not yet FDA approved, binds directly to the receptor, the IL-5 receptor on the eosinophil, also on basophils. All of these serve to reduce eosinophils, the progression, the proliferation of eosinophils, and that obviously reduces a certain portion of inflammation, particularly in patients who are eosinophil driven. The thing about MEPO is that, this was a study of 20 patients, randomized, double-blind, placebo-controlled, in patients who were refractory to intranasal corticosteroids. And you can see here that 12 out of the 20 had very nice responses at about 8 weeks. But there were some patients who just did not respond. And what we're finding with the IL-5 drugs is that you're either a really good responder or you're not a good responder. And I think you could say that about most medications, but there clearly is about a 60% response rate and for patients who do not respond at all, and you could see that only one patient responded in the placebo group, with the most common side effect being headache with mepolizumab. But mepolizumab did show a significant reduction in the need for sinus surgery or repeat sinus surgery, as you can see here in these charts compared to placebo. The Synapse study was another study of a larger number of patients, and it's randomized double-blind and really got the approval with patients who had, again, severe nasal polyps, a nasal polyp score of greater than 5, with the difference in nasal polyp score being about 3/4 of a point, and the VAS score reducing by 3, and a significant reduction in patients requiring surgery, with adverse responses being primarily that of headache. Benralizumab, not FDA approved. It's the anti-IL-5 receptor monoclonal antibody. And the reason in this Astro study, it really there is a significant difference statistically in the nasal polyp scores and nasal blockage scores, but the clinical significance of this really does not seem to be as robust. So we're going to go to an audience polling question. And overall, I'd like to ask, how willing would you say your patients with CRS with nasal polyps who are eligible are in trying a biologic? How willing are they to try a biologic? Extremely willing, very willing, somewhat willing, not very willing, not at all willing, or it's not appropriate. And while we're waiting for the response, I'm going to ask Dr. Cohen, what do you think about your patients' willingness, or do they have any thoughts about this? I know you're in the VA system, but do you have any patient feedback on biologics?
Yeah, so I tend to go to the biologics and the patients that I've already operated on that I can't seem to really make much better. And I think that the biggest question that they have, they don't mind the injection. What seems to be the catch is when they say, well, how long do I have to be getting this medication? And I kind of just shrug my shoulders. I'm like, yeah, for the foreseeable future, because we really don't know. And that's the harder sell. It's not so much, okay, we were going to do an injection every 2 weeks. It's that it's just for the duration. I will say that I have been incredibly surprised in these very, very tough to treat patients that I've reached to the biologics. I've really been impressed with how effective they are in these post-surgical, sometimes 3-4 surgeries, multiple rounds of steroids. And in the patients that I've then reached to the biologic, they really have cleaned themselves up. Of course, when they stopped doing the biologics, within about a month, their symptoms came back. So I think that a lot of the patients are very, very receptive to the idea. I think that the next hurdle is this, we're not really changing the disease, we're just kind of shoving it under the mattress.
Yeah, and I think the other thing we have to realize is that when we're treating patients, just like with, there's very rarely a patient who's going to require just one modality of therapy. They often require multiple modalities. They can't just require surgery alone. As you know, surgery by itself is not going to stop the inflammation. And biologics are forever, at least until we come up with a cure. So, oftentimes it's an interdisciplinary, multidisciplinary approach to these patients, and they're challenging, and they also have to buy into the idea of what's the expectation of each treatment. What will surgery accomplish? As you mentioned, what will surgery accomplish? You mentioned that. What will a biologic accomplish? And so sometimes you have to just, make sure they understand. So our physicians answered that the most frequent responses were somewhat willing and not applicable. But when we asked a similar question of patients about a month ago, patients who had just completed an educational program on biologics, about 33% of them, the most frequent response was that they were somewhat likely to consider initiating a biologic. And the other responses were extremely likely, very likely at 17%, and not at all likely at 17%. So let's go to strategies to improve outcomes. What's important here is that you engage patients in shared decision-making, because they have to be buying into what you're doing. They have to know this is the expectation of what you're going to do. This is what surgery can accomplish. This is the limitations of a biologic. This is the limitations of a course of corticosteroids. And so patients need to be involved. And so let's listen to Jack, who's a patient with nasal polyps, CRS with nasal polyps. Let's listen to him discuss his experience working with his physician to arrive at a treatment plan. Jack.
Around my senior year in high school, which is about 5 years ago, I just started having I got a sinus infection one time, and then it just didn't really go away after antibiotics. And I had a lot of sinus pressure and pain up in here, just kind of constant nasal discharge and runny nose and stuffiness and congestion. And after a couple months of that not going away was when I started seeing like ENT specialists and kind of launched into my whole polyps journey. I think once I landed with my current doctor at UCLA, it's always been made clear to me that it's my decision. But she strongly encouraged surgery just because they were so impacted that at some point they were going to have to get removed. And the hope was that, they wouldn't come back, because for a lot of people they don't, which that wasn't the case for me, unfortunately. As far as treatments go, I've done obviously the nasal spray, which most people do, with a lot of steroids, and then also the like sprays, not just the water rinses. I've done balloon sinuplasties. I've done more invasive surgeries. I have also tried a biologic, and then of just kind of a constant recurrence of antibiotics as well. It is important to me to be involved in those decisions, especially as I've gotten older, and things like surgeries, come with several week recovery times and things that are going to impact my availability for school and work and sports and stuff like that. It's definitely important to me that I kind of have the final say on that stuff, since it's my body that's going to be experiencing the, side effects of whatever I go through. And I have appreciated that about my last couple of doctors that have certainly taken, my life outside of the surgery into consideration, or other treatments that we've tried.
So shared decision-making. Patients need to be involved, the patient and the healthcare provider. Patient brings his values, lifestyle preferences, previous experiences that they may have had in the healthcare system, where the healthcare provider is going to, bring forth the diagnosis, talk about what the treatment options are, what the potential benefits, harms, what to expect from your treatment. I mean, this is how shared decision-making is done. And so the benefit of these decision aids and shared decision-making really are multiple. You get psychological benefits, clinical benefits, and also the healthcare system gets benefits. So this is really important, that the patient's involved and they understand what they're getting into and what the expectations for each step of the treatment is. So at this point, we're going to look at questions and answers. I think we have time for a few questions. And I'm going to start with this question: do biologics shrink existing polyps, or do they just prevent polyp formation? So they kind of do both. I mean, you saw on the slides that some of the biologics reduce the size of polyps, maybe not as dramatically as taking a surgery, which would take let's say a grade 3 polyp and bring it down to 0. But if they do reduce the size of them to some degree, I find that they're mostly effective at preventing regrowth in patients, especially once it gets to a certain point where the size is very large, that if this is a patient who's known to recur and has not responded to topical corticosteroid therapy, this is a patient who may benefit from using a biologic as a prevention. Noam, do you want to take a question? How about the new deliveries? Who is a good candidate for the new steroid delivery system? No, you've done a lot of work in that area. I think you're muted.
Sorry about that. Yeah, I'm good. All right. So the classic ways to get steroids into the spray was just with a mist spray. And that was really focused on patients with allergic rhinitis, not nasal polyps. And the target organ for classic nasal sprays was the head of the inferior turbinate and mostly the inferior turbinate. And that's what we were really doing up till about 15 or 20 years ago. And then the idea of using irrigations to deliver the steroid with a compounded effect. So the high volume irrigations not only mobilize all the inspissated and infected secretions, but they also deliver a medication. And at that point, we started realizing that the efficacy was not necessarily just the large volume, but was that retrograde delivery. And I kind of alluded to this, but if you look at the non-operated cavity, the ethmoid cavity and all those little bony partitions basically deflect anything that we inhale inferiorly and medially. So if you're breathing dust in, the dust is being bounced to the bottom of the nose. If you drive in reverse and you go from the back of the nose forward, all of those deflectors are actually driving that dust up into the sinuses. And so if we basically get a retrograde medication delivery, it's a lot more effective at getting these anti-inflammatories up into the sinonasal mucosa. And that's the idea behind putting the medications into the irrigation bottles and also with that exhalational delivery device, is that it's a retrograde delivery. And so a lot of patients don't need that. If it's just a little bit of allergic contribution, or if it's really just in the middle meatus, the standard therapy would work, but it's for those more aggressive polyps that have filled up the whole cavity, where we want to get that retrograde flow, that it's going to be more effective.
Well, thank you, Dr. Cohen, and thanks to our audience for the great questions. I would also like to thank Regeneron Pharmaceuticals and Sanofi for their support of this important educational activity. Please remember to view our companion session, Breathe Easier with Severe Asthma, the role of current and future therapies in reducing exacerbations and gaining control of your symptoms, on demand now at immunologylive.com. And please remember to complete the post-test at the end of the session to secure your CME credits. Please visit immunologylive.com to view today's session along with the other sessions on demand. My name is Dr. John Basso. Thank you for joining us.